So I've just received handover about the 70-year-old gentleman who is believed to have fallen down the stairs. I've donned personal protective equipment before his arrival, and I would also be wearing an apron. Also, the paramedics have cleared his C-spine at the scene. First, I need to assess if there is any major catastrophic arterial hemorrhage. I do this by looking for any signs of blood on the bed around the patient and on the floor. If I don't think there is any signs of catastrophic hemorrhage, I am able to move on to the airway. If the patient is able to talk to me, I can assume that his airway is patent. If not, or are there any added sounds of breathing, such as snoring, stridor, or gurgling, I need to consider moving up the airway plan. I do this first by doing basic airway manoeuvres, such as a head tilt chin lift or a jaw thrust if I'm worried about his C-spine. Then consider using basic airway adjuncts, moving through to intubation and as a last resort, front of neck access. If I am then happy with the airway, I am able to move on to breathing. I assess the breathing for a maximum by looking and feeling for a maximum of 10 seconds. If the patient is not breathing, I need to move straight into my BLS protocol. If he is, I can move on to do a simple respiratory assessment. Do this by exposing the patient's chest to look and feel for equal chest expansion. I can then feel for the patient's trachea to see if it is central before listening to the chest. At this point, I would ask my nurse to retract all forms of monitoring, including an oxygen sats probe, a BP cuff, and at least a 3-lead ECG. If I'm happy with his breathing and there have been no changes, I can move on to C, for circulation. I can look at my monitor to check for the patient's heart rate and blood pressure before listening for his heart sounds. And then assessing for a central capillary refill time. 2, 3, 4, 5. It is normal if the skin returns to normal colour within 2 seconds. I will then feel for his abdomen to see if there's any free fluid causing rigidity. And quickly feeling all 4 limbs to check if there could be any signs of fracture that could cause major bleeding into the limb. If there have been, I then need to insert 2 wide bore cannulas and consider whether the patient needs any fluids and taking any blood tests that I require, including a glucose and an ABG. If I'm happy that there have been no changes in the patient's status, I can move on to D. If there have, I would need to reassess from A. So I test the patient's full GCS before moving on to look at his pupils. If I'm concerned about the patient's neurology, I can then move on to do a simple neurological assessment, including power and sensation. If I'm happy with the patient, I can then move on to E, which is exposure. So I'd expose the patient incrementally to preserve his dignity, to ensure that there is no injuries that I have missed. I will then ask my team to help me log roll the patient so I can assess his back. I can now move on to do a more comprehensive secondary assessment to ensure that all the patient's injuries are treated appropriately.